When I hear the word master course, it's very familiar to me because I listened to Osstem implant basic course, and at the time I had to place 3 implants in very wide bones in the mandibular low posterior side. So it was my first surgery, so I could have been nervous, but I did very okay without being nervous. So same as that last time. Now when it comes to basics of the implant, how to solve tricky situations, and how to place tricky prosthesis, all this knowledge is, I believe, only available through the Osstem's master course in Korea. I will do my best in my lecture to motivate you to do better.
최선을 다해서 준비하겠습니다.
Hello, I am Dr. Jung Hyun-jung of Yonsei Hill Dental Clinic. For successful implant placement, the most important thing is understanding anatomic conditions and structure of the surgery site to avoid risks and to avoid complications. This is very important. So understanding the blood vessels and the anatomic structures and nerves is important for successful and satisfactory results. Today, we are going to look at the maxillar side, which is tricky because there is sinus. So this is what I'm going to cover. I'm going to first start by looking at the maxilla morphology. Then I'm going to talk about the blood supply and nerve distribution of maxillar side. Now, at school, you would have already learned about the anatomy of the maxilla, but we are revisiting this again for successful implant placement. So, if you are trying to place implant the maxillar side, what are the things you need to look out for in terms of anatomic structure for anterior as well as posterior is what I'm going to cover also. First, about the maxilla morphology. Now, this is the anterior view, and you see the maxilla and other related bones that are very much complexly related. And it's very well drawn morphology. Now, the beige colored area is the maxilla bone area. And from the nasal cavities and also under the eyes, infraorbital foramen exist. This infraorbital foramen is where the second branch of the fifth cranial nerve and through the nasal cavity, middle and inferior nasal concha can be seen. This concha is also called as turbinate, and this will be more explained when we talk about sinus. Inferior nasal concha is forms the medial wall of the sinus, and the medial nasal concha is lower than that. It's where the ostium opens, so anatomically it's very important area. The maxillar side, if you see from intraoral view, you see the incisive foramen here. This is during the flap surgery on the maxillar side. You see this very often. And the third molar inside, you see the greater palatine foramen. Through this, descending palatine vessel and greater palatine nerve flows. These nerves and blood vessels is responsible for senses and blood supply. This is something probably seen often in orthodontics, and if there's an ideal teeth arrangement from the anterior view, you would have a bit of a buccal angulation like this. And also on the right side, if you see from natural side, all teeth are angulated mesially. And this is what you see the axis, and on the buccal extension, on the upper posterior side, the midline exists. If there is a missing tooth here and you want to do implant restoration, then considering the opposing tooth, you have to make buccal angulation. If for edentless patient, you want to do implant restoration, then the landmark, anatomic landmark, science forearms position, or the curves and angulation, the midline, and also opposing teeth angulation and positions all needs to be taken into consideration. Before placing surgery, whether natural teeth exist or after extraction, a lot of time has passed, hence resulting to resorption based on such conditions. The bones and the bone conditions will be all different. First, when was the teeth extracted, and second, whether there was periodontitis and severity of it, and thirdly, the condition and type of prosthesis, all could result in higher bone resorption, especially the upper anterior side. The area bone resorption might be very severe. So often you see you will need to do bone grafting. If after extraction, the bridge has been used for a long time, then as you see in the CT picture, the bone width or the thickness can be very thin. So the bone, if it's very severely resorbed, then final restoration, position, the implant angles and bone width all needs to be considered. So 3D DT-based diagnosis is essential. On the maxillar posterior side, the bone height is important. After extraction, if the time has passed a lot because pneumonization, there could be a lowering of the margin. And if there is a bone is becoming lower, and you have to do sinus grafting for implant placement and final restoration. Depending on remaining bone height, for sinus grafting, various approaches are recommended. And this one will be probably covered in the sinus lecture. Lastly, as you see on the right side, there's a severe periodontitis or implantitis, meaning bone height is close to 0, then the implant positioning could be tricky. If you see this during surgery, you might be at loss. Because of this, periodontitis or implantitis resulting in bone resorption, you need to understand about this, and before extraction you need to explain this fully to the patient, and you need to have an accurate diagnosis. So this type of case would require sinus as well as vertical bone grafting, and this will be covered in other lectures. Secondly, let's talk about blood supply of maxillar side. Now from heart, common carotid artery comes up, and it's divided into external carotid artery and inferior alveolar artery. Inferior side goes to brain, and external carotid artery provides blood to the face and neck. You are very much probably familiar with this information. Of that, maxillary artery supplies blood to maxillary side. This has many branches and flows to the front of the maxilla side, and that can be divided into 3 parts. The first part is mandibular part, and inferior alveolar artery is where it supplies blood to the mandibular side. Secondary part is pterygoid part, and deep temporal pterygoid and muscetary and buccal artery. So it's related to mastication nerve. Lastly, third part, as you can see, relates to blood vessel supplying to the maxillary side. And also in terms of veins, as you can see, pterygoid plexus is something that you have to remember. When placing implant on the upper posterior part or for sinus grafting, if you use blocks or if you have too deep vertical incision, then you could touch this pterygoid plexus, result in heavy blood loss. So you have to be very careful. Thirdly, let's look at the nerve distribution of maxilla. The fifth cranial nerve, which is trigeminal nerve, is one of the biggest nerves and in the brain, composed of most of the sensory nerves and some motory sensory components. It's divided into three branches, and second branch, maxillary nerve, is on the maxilla side. This maxillary nerve is related to maxilla, nasal cavity, sinus, and palatal sides sensory nerves. It can be divided in four groups, and from the cranium branch to pterygopalatine fossa branch, you also have infraorbital canine branch, and also there is terminal arborization to the face. Of those, the second part, from pterygopalatine fossa to the posterior side, you have posterior superior alveolar nerves, and also the third part from interorbital canal, middle, and anterior superior alveolar nerves are related. Next is in actual implant placement. We are going to look at what's anatomical structure that's related. As this deals with possible complications, it will be less boring as it deals with the information you need to know anatomically for possible complications. So in the middle, you see the nasal cavity, and on both sides, you see sinus, and the ostium of sinus is from the top of the medial wall of sinus to the middle of the nasal cavity. It opens up. But on the anterior side, if there is a lot of alveolar bone resorption or the bone height is naturally low, then during flap elevation, nasal cavity's inferior margins can be exposed. But in the anterior side, the buccal side, there's a lot of muscles. So for clean elevation to the periosteum, periostal elevator, sometimes a lot of force is put on. Then during the nasal cavity, thin and convex nasal spine exists. If too much force is put in, accidentally, instrument could penetrate the nasal cavity. It happens rare, but you need to be cautious. Also, on the anterior side, there is incisive canal and sphenopalatine septal branch, and also greater palatine artery, and also the nerves, mesopalatine nerve and greater palatine nerves. They all form anastomosis here. But on clinical setting, when you have implant the central incisor, incised canal can be sometimes a problem. First, this incised canal can be too big. For ideal central incisor implant placement, some of the fixture could end up inevitably the incisive canal. If such penetration is minimum, then from the cortical bone one, you can gain initial stability and will not hurt the prognosis of implant. Rather, it could be give you the solid ground for initial stability. Next, if there's a lot of bone resorption, so before implant placement as a site development, you sometimes have to do vertical as well horizontal bone grafting. Then, after fully isolating canal, then you do lateralization of the nasopalatal nerve, and then in space you do bone grafting, or in the incisive canal, the bloods and nerves are cut and eliminated and do bone grafting, and still you will not be able to hurt nerves. I mostly prefer lateralization.
라테럴리제이션을 더욱 선호하고 있습니다. 마지막으로
Lastly, on the posterior side, things you need to consider in implant placement, in other words, the anatomical structure you need to take into consideration. Here, there are 4 kinds of paranasal sinus. Those that are related to implant surgery, maxillary sinus are closely related, but beside that, you have this type of sinus. So in total, 8 sinus exists. Of those, maxillary sinus is volume-wise about 15 cc, and that's the same as the cork of the wine. So I think it's easy to imagine. And this maxillary sinus is pyramid shape, and the base faces medial wall, and the apex faces lateral wall. Now, because the maxillary sinus floor, due to normalization process, after extraction, it expands downwards. And this sinus membrane, which is also called Schneiderian membrane, there's a lot of mucus gland, and it's called pseudostratified columnar epithelium. And from goblet cell always to the top of the mucus is formed, so coming air becomes moist, and the mucus actually cleans the inside. The cilia actually flows mucus into one direction, and the mucus that moves to the ostium goes out through the nasal cavity. If you use the crestal and lateral approach and do sinus bone grafting in that way, but sinus membrane perforates, then the bone material could block ostium. That could result in sinusitis or infection, so you need to be careful. And in maxillary sinus, of the 6 walls, 2 that relate to clinical situation, lateral wall and inferior wall. Let's look a bit deeper into this. On average, in lateral wall, the thinnest area will be interdental area of second premolar and first molar, and the thickest area will be interdental area of the first and second molar. Now, the thickest wall on average is about 20 millimeters. And on the CBCT, mostly the thick zygoma comes downward to the maxillary bone is between first and second molar. And this area, as it goes to the back side, forms such a curved line. And when you open lateral window to gain visibility, window size as well as the range is something you need to be very careful about. Now, the molar root infects the shape of the sinus inferior wall. In type 5, it's very irregular and rough, and that's a possibility is low with 9.1. Most cases is flat, as in type 1. That's what report says. But if you are planning for sinus bone grafting, you have to have a accuracy CT diagnosis to avoid any unexpected situation during surgery. In inferior wall, you have maxillary sinus septum, and this septum mean height is 7.9, but it can be as high as 17 millimeters. Hence, when planning to place implant, if the septum's height is lower than implant apex, like on the left, have one wide window and isolate the septum and do fully sinus membrane elevation would be easier. But if the septum height is high, it's better to have two windows and have a separate sinus membrane elevation. That would be easier. In the sinus bone grafting, to make safe in making lateral window, there is one more thing to be considered, and this is extraosseous and intraosseous anastomosis. Maxillary artery branch, you have infraorbital artery and posterior superior alveolar artery, and those two has anastomosis to make this. So on the lateral wall mucosa, you have extraosseous anastomosis, and the blood that goes inside the lateral window is called intraosseous anastomosis. The location is unobserved in the bone surface on the posterior side to the extraosseous. The distance is 23 millimeters. And from the bone's surface to the intraosseous anastomosis, according to reports, it's 18 millimeters. But after extraction, bone is restored, hence changing the bone height, then the number becomes less credible. So, in maxillary sinus from inferior wall to intraosseous anastomosis, the distance was measured by this journal literature. So reference that you could think that you can meet blood vessel by about 9 millimeters. You need to careful. So here, the bone and sinus grafting needs to be done together. So if the flap needs to be opened wide, the vertical incision or release incision could result in rarely, blood rupture. So you need to be careful. Extraosseous anastomosis. For the intraosseous anastomosis, as the blood is hidden in the bone wall, so because that is likely beforehand, you need to have full knowledge of the blood flow and use it for diagnosis before CT. As the blood contracts, because it's mostly less than 2 millimeters, leading to natural hemostasis, so you don't have to worry. But rarely, if it's more than 2 millimeters of blood flow, then to gain visibility, ligature, equilateral cautery, or direct pressure is needed to stop the blood flow before moving to bone grafting. Lastly, on the palatal side, in the incisive canal, blood flow and nerve has anastomosis, especially for soft tissue grafting. Connective tissue needs to be harvested on the palatal side. You need to have anatomical knowledge. So, let's summarize today's lecture. First, you need to have understanding of the anatomical structure on the maxilla sides, and based on that, placing fixture in the right angulation is important. Right location and have right angulation is important for also the next steps success. Also, knowing the resorbed pattern is also of the bones is also important. Next, blood supply and nerve distribution is also important. On the artery side, maxillary artery blood flow and nerve distribution. And on the vein side, pterygoid plexus is to be remembered. On the maxillar side, the fifth cranial nerve, trigeminal nerve, second branch, maxillary nerve is also something you need to be mindful of. And in terms of structure-related advanced surgery, the anatomical structure and also blood anastomosis, septum, sinus membrane, ostium needs to be all remembered for success of surgery.
합병증 없이 시행할 수 있을 것입니다. 이번 시간
I hope this lecture has given you information about anatomical considerations to be made for implant dentistry. And I hope by gaining more experience, you will have successful surgery. I'll see you next time at another lecture. Thank you very much.
함께 해주신 여러분 고맙습니다.